So I will be very happy to introduce the first speaker of this session, Professor Maura Dandri, who is from the University Medical Center at Hamburg-Eppendorf, and she studies viral hepatitis, and in particular how the virus interacts with the hepatocyte and with the cells of the immune system. Dr. Dandri, please, you can project your screen.
Yes, I do it right now. I just also had to switch on the voice, otherwise it will be difficult to follow. And yeah, now can you see my slide?
Yes. Yes.
That's very good. Okay, first of all, welcome everybody. And of course, good morning, good evening, depending where you are in the world. And thank you for the kind introduction. So my task today is to focus on the cccDNA, a source of serum biomarker, which is, from one point of view, it's a very, it's a huge job, but it might also be considered relatively easier, since we know that the cccDNA is the key molecule in HBV life cycle and also responsible for the persistence of chronic hepatitis B infection. So just to remind you what was nicely explained already last week, we know that the cccDNA is a mini chromosome. Is a mini chromosome, which mostly is first generated from incoming virions. And we know that the virus replicates by producing an overlength RNA intermediate, the pregenomic RNA. And also from the cccDNA, different subgenomic RNAs are produced. So, but we also know, meanwhile, that HBV can also integrate, and that the integrated sequences might also contribute to produce subgenomic RNAs and protein. But still, the cccDNA is responsible for the production of a high variety of viral components, which we are now to see that are released in the serum, from the DNA-containing particle, RNA-containing particle, S antigen, and E antigen and correlated antigen. So it's really the main player here. That means also that if we can eliminate the cis-DNA reservoir, this would lead to a sterilizing cure. But we know very well that it's a very difficult aim to achieve. So let's say that the reduction in activation of the cccDNA might actually lead to a more achievable goal, so to a functional cure, which is mostly defined as loss of S antigen. But cccDNA is a central molecule, but just to keep in mind, the determination of amount of intrahepatic amount and activity remains very challenging, because we do need liver biopsy, which is required to quantify the cccDNA, and this is an invasive technique. To cope with this problem, models can be used, such as humanized liver chimeric mice, where HBV infected human hepatocytes build the cccDNA, and different RNA and viral protein are produced. But there is also a further difficulty, challenge, which is a technical challenge, since the coexistence, there is the coexistence of nearly identical HBV DNA molecule replicative forms that gives this nice smear in the southern blot, which makes quantitative quantification of the cccDNA quite difficult. And this actually is the main challenge that we also, so we were tried in this concerted harmonization effort in a collaborative projects also to improve the method, the sensitivity of determining cccDNA by PCR. So we have different serum markers that are produced from the cccDNA amount. And as we know that as the therapy are developed, there is really an urgent need for non-invasive biomarker which reflect cccDNA amounts and expression in the liver. We need this to monitor therapy efficacy, to identify stratified patients that might achieve sustained virological control of treatment, and also to predict HCC risk. I would love to say that also we need this marker also to understand better the mechanism regulating cccDNA amount and activity. But I'm afraid that without biopsy of model, the liver sometimes remains a black box. So let's have a look at the S antigen. So the S antigen is a classical marker, mostly derived, just to remind you, from the subviral particle. We know that its clearance is considered the most important clinical endpoint, and its loss is associated with histological improvement and reduced risk. But if we use the polymerase inhibitor, the most commonly drugs nowadays used, we know that we can very efficiently lower the DNA in serum, but this drug do not affect directly the cccDNA. That means that the production of RNA as antigen is not expected based on the mode of action to change. And the patient study show that NUCs have no very limited impact on S antigen level, and also the cccDNA amount seems to decrease quite slowly. This might, however, also be due to the fact that the DNA suppression is not complete under therapy with nucleoside analog. So the correlation, we know that between quantitative S antigen cccDNA level varies between studies. And this might also be due to the fact that integration might contribute to S antigen production. So, but accumulating evidence indicated the S antigen level, especially at baseline, might mean correlated often with the low amount of cccDNA in the liver, plus minus, of course, contribution from integrated sequences. And we know already that the low S antigen level also are a good predictor in preventing relapse after stopping nucleoside analog therapy. And the decrease of S antigen is also a predictor, might be a good predictor of interferon response or efficacy of other novel therapy like siRNA. But this means again that we might have, depending on the mode of action of the drug, that we might have less RNA in the liver because of degradation or because of decreased activity. But doesn't necessarily mean that the level of cccDNA are changing. And particularly looking at the role of interferon, this is quite complicated because besides having immune modulatory effect, we know meanwhile that interferon alpha also decreased the acetylation status of cccDNA bound histones, leading to reduction of S antigen, E antigen, and other markers. So there is also an epigenetic suppression of cccDNA transcription, which can be induced by interferon, pegylated interferon alpha, and also some partial degradation. Meanwhile, we also know that this complex, the SMAC5/6 complex, play a key role in cccDNA regulation and silencing. But let's have a look at further markers, serum biomarker, like the correlated antigen. The correlated antigen actually measures combined reactivity of different proteins, which is the E antigens, the core related antigen, the core antigen, sorry, derived from the core protein, and the 22 kilodalton pre-core core protein. So this it's actually heterogeneous mixture, kind of cocktail of protein, which might be a little more difficult to, if you really want to understand what is coming, which protein mainly contribute to this detection in this assay. But the good thing is that by the correlated antigens, actually, this protein mostly derive from the overlength pre-genome and pre-core. So they are mostly derived from the cccDNA, so far as we know. And if we look at the study, these are just to take some example from the work of Barbara Testoni, the study showed that actually the correlated antigens level correlate well with the intrahepatic cccDNA loads and also with the transcriptional activity of the pregenome, of the transcriptional activity, which was measured in relation to the pregenomic RNA amount per cccDNA amount. And what they observed that among e antigen negative patients, the correlated antigen positive actually tend to show higher cccDNA transcriptional activity, positive for the correlated antigen, as the patients were correlated antigen negative. The study of Wang also nicely showed with a huge cohort of patients that the correlated antigen correlate with intrahepatic cccDNA level in NUC-treated patients. And also this level was shown to predict clinical relapse after stopping NA treatment. But again, many patients remain negative. So the sensitivity of the current correlated antigen assay, I think, needs to be still improved, especially to work well, to be very sensitive when low amount of cccDNA, when the amount of cccDNA are low. So let's come to the serum biomarker, HBV RNA, as its potential as serum biomarker. We know actually, meanwhile, that pregenomic RNA, spliced RNA, and also xRNA are found in serum. This can be released from naked capsid and envelope particle, maybe also from exosome. And this is shown by many studies. Coming back to quite early study of the Wang in the study in 2016, it was also nicely shown that HBV RNA in serum can be present as 3.5 pregenomic RNA in viral particles. And this was also shown from the more recent study of Prakash et al., that actually this RNA in serum is present in viral particles with the densities which are similar as the particle containing HBV DNA. And that actually these particles are produced at high rate, similar to those containing DNA particle. But HBV RNA level might actually vary according to antigen status, disease status. So the study with Van Bommel was also showing that in e-antigen, there are significant difference between antigen positive and negative regarding the amount of HBV RNA in serum. And actually, years ago, we were also observing in a cohort of patients, untreated patients, that e-antigen positive, that e-antigen, or let's say e-antigen negative patients show actually lower cccDNA activity, also measured pregenomic RNA copy per cccDNA. And we know from the DNA study, also from the old study from Verle Lapostole, that actually this also e-antigen negative patient also have lower cccDNA amount, so lower activity, lower cccDNA activity and loads leads to lower HBV RNA in serum. But measurement might also be difficult, or let's say the interpretation of the amount of the ratio between DNA and RNA in serum might be also complicated by the type of genotype, viral genotype difference, and the speed of the rate, the speed by which, for instance, the virus is reversed, the RNA is reverse transcribed, which might also affect level in serum. Using humanized mice, we also confirmed that we can also see RNA, pregenomic RNA in serum of humanized mice, and that when we treat these mice with polymerase inhibitors, we do not see, expected as the mode of action of NUCs is, a reduction of RNA in serum. The situation is, however, quite different when we treat these mice with the pegylated interferon alpha, where we observe, as was mentioned before, a reduction of both DNA and RNA in
we must
serum.
be finishing soon, Dr. Dandri?
Yes, a couple of slides actually.
Yes.
There also have we try to correlate, also important, the amount of serum pregenomic RNA level with the amount of pregenomic RNA in the liver, which shown that correlates quite well. And also in untreated mice, it correlates well with the amount of intrahepatic cccDNA. But this correlation is lost when in mice that were treated with interferon alpha, because there is less cccDNA activity. So coming to the point that this measurement might serve as good surrogate marker to assess the impact of drug affecting RNA level and activity. An example also with the capsid inhibitor in patients and in mice, we can have a good reduction of RNA in serum, also without causing substantial change in cccDNA loads. So to sum up this part, we can say that if we have a low serum pregenomic level, this corresponds to low level in the liver, which might be due to the low level of cccDNA or activity. And by the new therapy, actually, this decrease of RNA might be a good predictor of therapy response. So to conclude, we can say that different non-invasive markers reflecting cccDNA amount and activity have been identified. Maybe correlated antigen pregenomic RNA are promising, since they are more likely derived from the cccDNA for the type of approach that I was mentioning. And just to mention, also the composition of the RNA species might also serve as a marker of cccDNA mutation turnover, as was mentioned in a very provocative recent study. But to conclude, I still think that more translational study, biopsy in vivo model are needed to fully evaluate the potential of this marker and to understand the impact of novel therapy on cccDNA loads and activity. And with this, I'm finished, and I thank you for your attention.
Thank you so much. I think in the interest of time, I think we will ask that individual questions be sent to you, Maura, and you can address them privately. And now we will move on to the next speaker. This was a very interesting presentation. Thank you.